Hi, everyone. I'm Emelia Bachman. Welcome. Happy Thursday. I'm so happy that you're joining us today. Hope I can answer some of your questions. Just to introduce myself again, I'm Emelia Bachman. I'm one of the physicians at Delaware Institute for Reproductive Medicine. Um, I work with Dr. Jeffrey Russell, Dr. George Kovalevsky, and Dr. Adrian Neidhart, as well as our incredible staff. Our main office is in Newark, Delaware. We have a new facility, as many of you may know, just down the street from Christiana. We're excited to show you our new space. So if you haven't visited, please come. And as you know, we also have satellites in Milford, Delaware, and in Chadsford, Pennsylvania. So we have 3 locations for your convenience, as well as many patients are doing telemedicine consults to just help them with time and help if they have a partner. Both partners can be available. Of course, we will always see you in person if you prefer that for a consult as well. And of course, you'll do your testing and treatment in our office, in whichever office is more convenient for you. I have some questions that we were already sent, and I'll also answer your questions just to give you a little bit of an introduction of what to expect when you come to our office. You will have a consult with one of the physicians, and this is, I think, really important to help let us know how you're feeling, what's been happening, to find out your medical history, prior pregnancy history, if you've had losses, how long you've been trying, and also to know your goals for your family. So these are things that are going to help us decide where we'll start with testing. For most people, the basic fertility testing involves, trying to figure out, what is the egg reserve? Are the fallopian tubes open? Is the uterus healthy and normal? If you have a male partner, is the sperm present and adequate? And also some other hormonal tests, which might be important, perhaps if someone has irregular periods or certain symptoms. And we also like to do all the preconception labs for pregnancy to make sure that you're healthy for pregnancy and that you have all the recommended, vaccines and no other abnormalities before moving forward. One thing I always love to teach people about egg reserve, and it is really important to know that when we test your egg reserve, these egg reserve numbers do not predict whether or not you're going to have a baby. They can predict response to treatment, and they are the tests that we have to try to evaluate where things are for you. As many of you may know, some people don't. If you're my patient, I've talked to you about this. Women are born with kind of a fixed number of eggs. Unfortunately, we have all the eggs we're ever going to have when we're 20 weeks in our mother's uterus. And they drop dramatically between 20 weeks and birth. And then each one of us has a different slope in our life. So they not only decline in number, but they do decline in quality as we get older. So it is really important to know that while these ovarian reserve tests can kind of tell us like a snapshot in time of where we are, they don't predict whether or not we're going to have a baby. And really, it is our age that is our primary predictor. So some tests that we do, one is we call it a day 3 FSH or follicle stimulating hormone. This can be done on day 2, 3, or 4 of your cycle. And we check that in conjunction with an estrogen level. And so at this time in the cycle, the brain is signaling the ovary, and the ovary needs to give a signal back. And so this number actually should be low. And remember, each test depends on the assay in which it's done, whether you're getting it at our lab or LabCorp. So it is good to look at those reference ranges. But typically, FSH levels pretty much, greater than 11 or 12 may signal a sign of reduced ovarian reserve, but these can fluctuate month to month. So again, it doesn't mean that you won't get pregnant, but it might mean that there is maybe some decrease in egg number occurring. And this can vary month to month. And typically we just want a normal level somewhere between, 2 to 11 or so. depending on the lab. And similarly with that, the estrogen level needs to be low at that time of the cycle. So sometimes when the estrogen gets too high too fast, that can also be a sign of a little bit of a dysfunctional cycle. Again, that's a little bit of a soft marker because every month can be different, right? Every month, our body recruits a different group of eggs and will select one to be the chosen one if we're having regular periods. Another test we do is something called the AMH, or anti-Mullerian hormone. This can actually be done any day of the cycle. And AMH is secreted by the ovary and by the supporting cells of the egg and can kind of give us a sense of the basket of egg reserve. So typically we think most women live somewhere between 1 and 5, with 5 being really, really high, and there are different age-based medians of AMH. And again, it's really important to know you can still have a low AMH and still get pregnant, right? But it does help us predict how someone may respond to either IVF or if they're planning on egg freezing. And typically something less than 1 may just predict a low response to those treatments. But again, does not mean that you will not get pregnant. So these are not on their own a good test of fertility themselves. The other test of egg reserve is something called the antral follicle count. And this is where we bring you in for an ultrasound, typically on day 2, 3, or 4 of your cycle. And we can measure those small follicles, right? A follicle is a fluid-filled structure in the ovary, which has your immature eggs. And so that baseline antral follicle count can also give us a sense of the egg reserve. Typically, when we see that number is less than 10, that can be a little lower, but that could be normal for someone who is potentially, over 40. We definitely see numbers less than 10, which are normal there too. Okay. So these tests kind of give us a sense of the egg reserve, but remember that we have had patients who've had perfectly normal results and still have difficulty getting pregnant, and patients have very, abnormal results and they get pregnant on their own too. So it's important that it's just one piece of the puzzle that helps us decide on treatment, and also maybe help decide in family planning and maybe how aggressive or not aggressive you might want to be with treatment. But I tell people, please don't be discouraged if it's low. We really should still do everything we can to help you. From there, remember, we want an egg to ovulate and we need a fallopian tube to pick that egg up. So we want the fallopian tubes to be open, and we do a test where we check the fallopian tubes, either a saline sonogram, HSG, or an HSG in radiology. And typically, your doctor will decide which one is probably better for you. And then we can look at the inside of the uterus as well. And both of those tests will look at that, or we can do an office hysteroscopy, or you can have a 3D ultrasound of the uterus. If you have a male partner, it is really important to check the sperm, and we can easily do a sperm test in the office. We offer both drop-off sperm, and we have, a room for collection in the office too, whatever you prefer. We have, a little instruction sheet for that. But that is really important. And I have a lot of patients who come to me and they say, well, Dr. Bachman, I know it's me. I know I'm not ovulating normally, or I know my tubes are blocked, or I know, I have endometriosis. But at the same time, it's really important to remember that 30% of couples may have more than one cause. And it's also important to have the whole picture if we're trying to figure out what the best treatment is for you. Now, for our same-sex couples and single patients, we do have, donor sperm, and we work with many donor sperm banks, as well as there's some patients who may have what's called a directed donor, or someone they know. Certainly, we need that person to get the appropriate infectious disease testing, genetic testing, and legal contract, but we can do both anonymous and directed donor in our office. I'm going to start with some of the questions now. We had some prior to the talk, we had some that were submitted. So one question is, I'm 38, husband is 42, been trying for 3 months without success. Best to just keep trying a little longer, or should I think about seeing a doctor, or both? Thanks again. I think I agree with both. So I think it really is important. Sometimes it can take some time, particularly when we're older, but we do want to see a specialist earlier so we don't lose time. And again, that goes back to the effect of age on our egg reserve and our pregnancy rates. So as we get older, the eggs become more and more genetically abnormal, so our pregnancy rates go down and our chance for miscarriage does increase. This does not mean that you may not be successful at 38. There are many patients who do not need my help, but it would be helpful. We do say over 35, it would be good to get an evaluation at 6 months. But if you would like to start an evaluation a little bit earlier, that always can be helpful, because maybe, we can still do some testing while you're trying and see where things are. And maybe if everything's normal, you try for another month or two, but then you're already, in our office and we can plan for some treatment if things haven't worked. Certainly always tell patients, I'm here to help guide you. We always want to make sure that you feel comfortable with the kind of the timeline of treatment, but it is important to seek help earlier rather than later, because then we can identify things. And certainly you can decide your timeline. Other things that are important to know, people also talk about, patients who are under 35 waiting a year. Again, that's a general rule, but if there are other issues, if you have irregular periods, really painful periods, if you have endometriosis, if maybe you have a partner who knows that there may be a sperm issue, it would be really good to we do recommend that you get help sooner than that, because it's not worth wasting your time if the periods are irregular for a whole year. Other things that, maybe couples know that they have a genetic condition, so they want that tested with IVF. So that is another reason to come to see us, right away. Of course, also our patients who are single or LGBTQ couples should definitely come see us so we can help talk to you about the range of options for the family. And I'm going to use that to segue into my first question here was two moms to be. What are the best options for lesbian couples looking to start a family? Like, how do you pick between things like IUI, IVF, and reciprocal IVF? I think this is an awesome question. So the first thing I always ask is I like to see you both together. Again, get your history. What are the ages of both partners, medical history, gynecological history, if they've maybe had obstetric history in the past, and really talk about everything. I also like to talk about the goals of your family. So do one of you want to get pregnant? Do both of you want to get pregnant? Do one of you want to use your eggs? Do both of you want to use your eggs? These are important questions so we can figure out, what would be the best way for treatment. For patients who are typically younger with no fertility issues and their tubes are open, they want to be pregnant themselves, then something like donor sperm IUI might be a good first step. I will say though, donor sperm, some insurances will cover some of the cost of it and many will not. So that can be really expensive. And that's where something like IVF, where it may sound like, oh, I don't need IVF because I'm not infertile, but the reality is the IVF success is a lot higher. So you're going to get a lot higher success and more embryos to be able to transfer with one vial of donor sperm versus having to buy multiple. At the same time, everyone has their own feelings of how they want to go about doing this, right? So that's why it's important for me to talk to you and any of us to talk to you about what are your feelings and how do you feel about a more less invasive treatment versus a more invasive treatment? How many children do you want to have? Again, who wants to get pregnant? And now reciprocal IVF could be like maybe I use my eggs and then my partner will put the embryo in her uterus, right? Or vice versa. So that's something that can also happen. So we really can do any of these things. And it's really a matter of what are your desires. But also some things might come into play like age and the results from fertility testing. So another thing, I do recommend full fertility testing, even though you might, you don't have infertility, you haven't tried to get pregnant, but there may be things that you don't know, and you also don't want to waste time or money, doing something that might not be as successful. So it's kind of a long answer to the question, but we really want to understand your wishes for the family, and then also what would give you the best chance for success. And we kind of put all that together. Hope that's helpful. And is there a starter pack for all the decisions we have to make? I know it's a lot, but I hope that was helpful for, just kind of explaining how we think about that, right? I always tell my patients, and I'm sure some of you who've seen me, you know, I think I will always, we will always be honest with you, but you have to look at what is the medical, diagnosis, what are the success rates, what are the treatments, but at the end of the day, we have to come together to a plan that you feel really comfortable with, right? What is the success rate for frozen embryo transfers? So that will depend on age. So for most women under 35, a success rate is probably around 50%. If the embryo is untested, if the embryo is tested, it is up to 60%. So across all age groups, if you have a genetically normal embryo, you roughly have about 60% implantation per genetically normal embryo. If you decide not to do genetic testing and you're just, transferring an embryo from IVF, as we get older, those success rates go down. So probably, in the later 30s, they may be about, 30, 40%. As you get closer to 40, maybe more like 20 to 30%, and over 40, probably, could be 10% or less. But if you're over 40 and you're lucky that you got enough eggs and then we made embryos and then we tested that embryo and we knew it was genetically normal, there'd be a roughly 60% per embryo. So I usually say it is good to have about 2 to 3 embryos per child. Certainly unless you have any religious or ethical concerns about having extra embryos, but certainly we've had many patients who've gotten pregnant on their first one, and there are other patients who may need to try multiple embryos, which I'm sure a lot of you are aware. For the insurance plans, we accept a lot of insurance plans. You can go to our website and take a look at that. They're listed, or even calling the office, or one of our patient navigators can help you with that. Trying to conceive over a year, the GYN just diagnosed me with PCOS. I'm wondering if I should come see you now or wait and keep trying. I'm 36. I think it all depends on if you have PCOS with regular cycles or PCOS with really irregular cycles. So if we look at data, about 30% of patients with PCOS, they may conceive on their own, but about 70% do need our help. And also, you are 36, so there's that age factor there too. So my feeling is, I think it would be smart to come right away. If you're having regular periods, maybe you do want to try for a few months on your own, but I wouldn't go much longer than 3 to 6 months. And certainly if the periods are either non-existent or very long in cycles, I would come and see us to help you. These are great questions. I also had another question. Does coffee affect the quality of the oocyte? We do not think that minimal amounts of caffeine will affect the oocytes. There are studies that perhaps very excessive amounts of caffeine might be associated with recurrent pregnancy loss or associated with lower egg or sperm quality, but we're really looking at, higher levels above, 300 milligrams a day. We really tell patients less than 200 milligrams of caffeine a day is likely okay. So it's kind of 1 or 2 cups of coffee a day. You can look up what you usually drink and see that, but we want to keep that under 200 milligrams, and that's fine. You don't have to give up everything. I'm an everything in moderation person. We also need to be reasonable, right? I know we all I think it's smart to be as healthy as possible. It's smart to make good choices, right? With caffeine, minimal alcohol, zero smoking. Smoking is really detrimental to eggs and sperm. There's a lot of data that it will greatly reduce pregnancy rates and cause early menopause as well. So we know that for sure. Obviously, we don't want any other drug use. And then, lots of fruits and vegetables, good proteins, good fats, eating more at home, less processed food. These things are all really, common sense. But it is important to know that, it's not your fault, right? It's really important that, sometimes we just can't change the effect of aging on our eggs. We can do every little thing we can. And I do encourage my patients to do whatever they can do naturally to try and help with, vitamins and healthy diet and good sleep and moderate exercise. But remember that it's not your fault. And we don't want you to drive yourself crazy either, because, while there are some supplements that are recommended, we don't have hardcore data that they're definitely improving egg quality or pregnancy rates. And I know there's a lot of data out there on the internet. I definitely would never argue with a patient who said, I really felt better when I changed my lifestyle and I lost some weight or I used these supplements. That's great. I think that's really good. And I think those things can only be helpful, but I also don't want you feeling like you're doing something wrong if you haven't been doing that for months and months. Okay. Um, Could I have endometriosis, painful periods, not getting pregnant, and swollen abdomen? Does it affect fertility? This is a great question. So, yes, potentially. So, endometriosis is associated with painful periods, pelvic pain, pain with sex, um, pain with bowel movements, urination, and this kind of sometimes you can have abdominal bloating, very heavy periods. So it's important to know that these things are associated with that. The gold standard for diagnosis of endometriosis is a laparoscopy, and that's a scope, meaning a camera. It's a camera that goes in the belly button, and we can take a look inside and see. What is endometriosis? It's when the glands that line the uterus, they can implant in the pelvis, and they can be on the uterus, on the ovaries, on the fallopian tubes, on the bowel. And there is a lining of tissue in the abdomen called the peritoneum. And you can see these little pockets of cells. They can be yellow, red, blue, black, brown, and they're pockets of cells that become inflamed with every period, and they can cause painful periods, and they can, be associated with infertility as well, as if they can affect the fallopian tubes, they can affect ovulation, and really it is an inflammatory process. So the way to know for sure is for someone to take a look inside. Now, for someone who's much younger, sometimes I do have some patients who are not trying to get pregnant. They might have had, concerns about endometriosis or PCOS. And so some of my very younger patients, sometimes we may try something like suppression of the periods with birth control or something to try and see if that relieves their symptoms. And then if that happens, that can be a clue that that's probably what's going on. Because certainly you don't want to take surgery lightly. But if someone is really having very painful periods and is not able to function and it's affecting their daily activities or they're affecting their ability to have healthy intercourse, we definitely want to know for sure. And it's also important that you do get a fertility evaluation too, because it is associated with infertility and can lead to difficulty getting pregnant. That having been said, there are really high success rates with IUI and IVF. So it's important to just see someone sooner so we can figure out what's happening. How long does it take to get an appointment with you? We usually can see most people within about 1 to 3 weeks. So you just call our main office. We also have an online form, and someone will get back to you within a day or two, and we will help you get scheduled. Yeah, what's the best way to know if we're ready to start fertility treatments, and how do we figure out which option is right for us? It's all so confusing. I know it is. I know it's really hard. So I think I touched on this earlier. I'll repeat myself a little bit. If you're under 35 and been trying for more than a year, if you're over 35 and trying for more than 6 months, you really should see a specialist. Now, you should see a specialist earlier. I do recommend probably someone who's 40, not waiting 6 months. And if it's been, 3 months or so, I would see someone, because that impact of age is so significant. And again, if you have symptoms, like I had mentioned, irregular periods, really painful periods, if you know there's an issue, you should see someone sooner. What's the process for using frozen embryos, and how long can they actually be stored before we use them? So for using the frozen, if you already have embryos created, then what we like to do is evaluate you and see, okay, how are the preconception labs? Is everything okay for you to get pregnant? Do an ultrasound. Also check the inside of the uterus to make sure there's no polyp or fibroid or scar tissue. Make sure the inside of the uterus is good for implantation. And so then once we do that and make sure that everything is evaluated beforehand, then we want to decide what is the right protocol. So how do we want to decide this? We want to make sure the lining is appropriate to put the embryo in. So we want to put this embryo in what's called the window of implantation, right? So in a natural cycle, after ovulation occurs, right, the embryo will grow in the tube and will implant in the uterus, right, roughly 5 or 6 days after ovulation. So that's where we want to time the transfer with that process. So there are many different protocols, but two of the most commonly used protocols are either a program transfer or a natural cycle transfer. A program transfer is when we use estrogen pills to make the lining thick, and then we use progesterone injections to then expose the lining to progesterone, to what's called decidualize the lining, and then to put the embryo in at the right time. Similarly, we can use a patient's natural cycle if you have regular periods, where we follow the natural lining and the natural follicle, and then we either, wait close to ovulation and then induce ovulation with maybe a trigger shot, and then put the embryo in a week later when it would have naturally implanted. And then we can also do some supplemental, either vaginal progesterone or injectable progesterone, whatever you prefer. So what is right for you? I think that's, you always talk to your doctor about what is, we talk about like the different processes. Neither is superior, but one might be better for your personal situation. As far as for how long they can be stored, essentially forever. They're in liquid nitrogen. And I think we know of the oldest frozen embryo, it's I think 24 years, that resulted in a successful pregnancy. It might be higher now, but theoretically they're good forever. Each embryo, if it's a good quality embryo, has over 95% chance for survival. So we see less than 5% that may not survive that warming process. And then again, depending on the age at which you froze them, right? So if you froze them when you were 25, they have the same chance 5, 10, 15, 20 years later. Again, as long as your uterus is still healthy and your other labs and everything are normal, which we would make sure we check before. You also, if you've done genetic testing on the embryos, then again, it's the same thing. It's going to be the same chance. So that's where, this idea of fertility preservation, where, either patients are freezing their eggs or freezing embryos for use for the future to preserve that fertility. Maybe they know they want multiple children and they want to save those for the future, and they're worried about that impact of age. And I think someone had asked a question about egg freezing. I'm looking into freezing my eggs and have no idea where to start in regards to finding a provider, understanding what is covered via insurance. I will need to go through IVF because I don't have a uterus. What recommendation do you have? Yes, you are the perfect person to do this. I think, again, as far as the insurance, it all depends on the insurance and the employer and what they decide. So you can see, either ask your HR or look at your plan. And then also, when you make an appointment with us, one of our financial navigators will help you, and they will look at your insurance and let you know what is covered, what is not, is an authorization required or not. But I think it'd be a good place to start would be just to find someone that you think you might connect with and have a consult about it and talk about the process and talk about your wishes for the future. And then we get some basic tests on the egg reserve, so just some blood work and an ultrasound. And then from there, we can see how will your body respond. And then our financial navigators in the office can help you understand what's covered with insurance. And then also, if it's not, then, look at like what the self-pay cost is and what that might look like for you. Okay, so I think really just having a conversation in the beginning is a really good place to start. And then we can start with getting some basic egg reserve testing and go from there. Okay. This is a good question. What is the biggest surprise or unexpected aspect of the IVF process for someone who's had a previous IVF cycle? So this is a great question. I think that some people, we don't realize until we're in it, like how inefficient biology is, which is really frustrating. So often we see, we get a certain number of follicles that are growing. What are follicles? Remember, they're fluid-filled structures that have the microscopic egg. And so we're seeing these follicles grow, right? And we're waiting until they get to a mature size. Then we're triggering ovulation. And then we're doing an egg retrieval, right? An egg retrieval is a vaginal guided, needle aspiration. And typically the ovaries, they mostly sit right near the vagina, and we can just gently puncture the vaginal wall while you're under sedation, right? So it's kind of like just a little sedation, not full general anesthesia, kind of like you get a colonoscopy or wisdom teeth. It's in our office, and we have anesthesiologists who come. They're wonderful. And the procedure really only takes about 10 to 15 minutes. We don't rush. It just doesn't usually take that long to get the eggs out. And so we gently aspirate the eggs. And then from there, we see how many eggs. So I tell my patients all the time, and if you talk to me, you know I've said this too, not every follicle has an egg, not every egg is mature, then they may not all fertilize, right? And then they may not all become embryos. And then all of those embryos, even if you're younger, they may not all be healthy. And I think that's really surprising to people, right? Like they see like unfortunately, one egg doesn't always equal one baby. Have I had that miracle happen for people? Absolutely, I have. And you're always over the moon when that happens, and it can happen. And I've definitely had some patients who've had a lot of eggs and they've, gone down to a few embryos, but then we really saw, hey, maybe this was really important to do this. And I've had some patients who maybe like didn't get what they expected, but they still had a good number of embryos. So everyone's different, right? You're an individual, the way your body responds, we're going to have different results. And many patients may need to do more than one cycle. Obviously, our goal is always to try to get you success with that one cycle, but depending on age and the egg reserve, we may need more. And that's where it's important to have a really transparent conversation with your doctor about what to expect. Well, this is a good question. Are frozen eggs better than fresh eggs? Thanks. So typically, well, you are going to lose some in the frozen process, right? So most eggs, if they're healthy, we usually see about 90% survival. But when you're using fresh eggs, you're likely going to get more fertilization and more embryos. That having been said, though, frozen eggs really can have, they do have an excellent use where, on one hand, if someone, like if I didn't have a partner and I really wanted to save eggs for the future, then I could freeze those eggs and then they would still have the same chance they do now. Now, I'm 46, so yeah. So that's not helping. That's not working for me right now. So I would be looking into donor eggs. And we also have donors who freeze their eggs. So we freeze the donor's eggs so that they can be bought in batches of like 6 or 8 or 12 for a patient's use. And the nice thing about that is that they're readily available, that donor's already gone through testing. And we may even have some data on eggs that are hers that have been used before, right? Has she gotten someone else pregnant? And they're there and they're easy to use. That having been said, if you want a lot of children, maybe using the fresh eggs might be better because then we might get more embryos in the end too. So I think both are really successful. And in the end, whether you use fresh or frozen eggs, that embryo you get to is still going to have the same chance, but with a fresh cycle, you might end up getting more embryos, if that makes sense, right? Because you may lose some of the frozen eggs in that warming process. But typically they are both really successful. It's just, yeah, you may get a higher yield from the fresh. Oh, that was really, thank you for that nice comment. You're awesome too. I don't know who it is, but so what vitamins do you typically recommend your patients take when they begin to see you? Also, what are your thoughts on CoQ10? So we always recommend a prenatal vitamin. We want that to have a minimal amount of folic acid, which is at least 800 micrograms. We also like it to have DHA, which is like the omega-3 fatty acids. Those are good for brain and eye development of baby. I like my patients to take a little extra vitamin D, although the data, again, is mixed. And then my thoughts on CoQ10. CoQ10 is an antioxidant. It's also used for anti-inflammatory. It's used for heart health. There are some small studies that show it may potentially help egg quality. Again, we have to be realistic and know that, one supplement may not erase, years and years of aging. At the same time, it's relatively safe. There's some small studies, and sometimes, again, we want to do every little thing that we can. So I think the risk benefit is really low that, taking some of that, it could potentially be helpful. And I think that's fine. And if you're going to do that, it's 600 milligrams daily. Again, it's important to look at, less processed food, lots of fruits and vegetables, good proteins, good fats, eating more at home. Those things are really important. But again, I wish if there was a magical diet, I would tell you, we would all tell you, and I know you would all do it because you're amazing and you always do everything we tell you to do. So, but I think it's always good to just do the best you can do. Right? Is it safe to travel after frozen embryo transfer? Yes, it is. It is safe. You may need if you're doing the progesterone injections, you might need a needle, letter. I think it's okay. Certainly I wouldn't do anything that would really like overly stress you out. Again, it's not, I hate to say it, it either is or it isn't, right? So either do we have a genetically normal embryo or not, or what is the age at which the embryo was created? And then what is the lining? Do we put that in at the right time? And then from there, you've done everything you can. You're taking the supplements that we tell you to take with the estrogen and progesterone, depending on the kind of cycle we're doing. So I think it's completely fine to travel. It is good to be closer when we're trying to figure out, are you pregnant or not? And that early stages of where we're trying to figure out, is the pregnancy progressing normally? Like making sure you don't have a biochemical pregnancy or an ectopic pregnancy. So that's why I'd like you to be closer to home for that but sometimes if life happens, so we can always get, labs somewhere else and we can send outside lab orders. So we usually like to be really flexible with you. A question, why does DIRM have a BMI cutoff for IVF? I will say ours is much more generous than other places. We obviously think that we believe everyone deserves a baby, and that is important to us. But we also want to make sure that you're safe and healthy and that you have a good success rate with pregnancy and that you have less complications in pregnancy. And also something with IVF is that you're going to sleep in an office. So our anesthesiologists do have some parameters that they just want to make sure that people are safe when they're going to sleep in an office. And we don't have, we are not intubating people in our office. That's not happening. So it is important that we just keep you safe. We roughly I don't think BMI is the best predictor of health. We know there's a lot of issues with it, but we do roughly say in our practice around 45. Now, we work with everyone. So if you really tried hard and you've really gotten close to that and our anesthesiologist is okay with you proceeding and we can get to your ovaries easily, then that could be a different situation. So we definitely look at you as an individual. We want to help everyone and we want to make sure that you get through the process safely and that you have a safe pregnancy. So it's a little loose, but ours is a little higher than other nearby offices. I have another question here. Does trying for IUI for more than one cycle increase the chances of success? Should you do cycles back to back for better outcomes, or is it okay to take a month off? When do we know that it's time to move from IUI to IVF? I think this is a really good question. So remember that each month is a different event, right? So whether you do them back to back or you have to take a month off, maybe because of life, or you're just a little stressed out or just need a break, that's okay. Each month you have a different set of eggs. Each month, we may help you ovulate with certain medications, and that is going to be a different egg that is ovulated, right? So one month doesn't make the other month better, if that makes sense. So I think you just have to decide. I do think it's best to continue to move forward because, with time that goes on, we're just getting older. But at the same time, there's nothing wrong with, taking a month or two if you're feeling like I need a break from all of this. Now, when do you decide to move on to IVF? So I'm going to assume that we've already decided that IUI was okay. Remember, we don't want to do IUI if both tubes are blocked, if the sperm is really low. Maybe if someone really wants a larger family and they're starting out later, something like IVF to save embryos for the future might be a lot better for them. But let's say you have open tubes, the sperm is adequate, or you're using donor sperm, and we're trying. When you look at data, the success rate really does plateau after about 3 to 4 months. I've had the lucky patient who said to me, listen, I don't want to do IVF. And I say, okay, that's fine. And maybe we got it on that 4th or 5th cycle or even 6th, but those are few and far between. I do have to be, transparent about that. So you'll see most people, if you're going to get pregnant, it will happen in that first 3 to 4 IUI cycles. And after that, we really think you should move on to IVF. Also, if we're seeing in the IUI cycles that maybe, if you have a male partner and you're doing IUIs, maybe if that sperm isn't washing out, we're getting lower numbers, then maybe we do need to move on to IVF at that point too. So it's always good to talk to your doctor. I always like to touch base, like before we come up with a treatment plan, we decide, okay, what are we going to do? I always tell my patients, let me know, we try to touch base in between, and you do want to at least give it, 2 or 3 months. Sometimes the first month doesn't work, but after 3, you really want to regroup. Okay. And sometimes, depending on the situation, you may decide to do one or the other. Now, IVF is always going to give you that highest chance for success in the shortest amount of time. But, again, in your individual situation, we have to figure out what's right for you. I wish I could actually see you. That'd be more fun. Good question. I really like this question. It's going to come back to what I said in the beginning. Does a high egg reserve mean that you will not deal with infertility, or does the egg reserve not correlate? This is an excellent question. A high egg reserve is not equivalent to live birth. It's always a good thing, right? It's always a good thing to have more eggs, right? That's not going to hurt you, right? I can't give you more eggs than you have. So having high numbers and good numbers, that's always going to be a positive. But that doesn't mean it's not a good fertility test. It doesn't mean like, oh, I'm fine, I don't have to do anything. It doesn't give us time to menopause. It doesn't predict live birth. And similarly, a low egg reserve doesn't mean that you're not going to get pregnant on your own. Actually, I've had many patients who've had elevated FSHs and low AMHs get pregnant on their own many times. So it's important to know it's the age that's the primary predictor. But I'm always happy when I see good numbers, and that's a good thing. But again, you can't take, we don't know the timeline that is going to stay. Everyone has a different slope, and we can't predict that. How do you choose which embryo to transfer? This is a great question. So we use 2 different things. There's the morphology, or how the embryo looks. So the embryos are graded based on how healthy the cells look, how either not fragmented they are, how many cells. It is a little subjective though. So we think that better grades do correlate with better pregnancy rates, but remember, this is not an absolute thing. So I've seen AA embryos unfortunately end in miscarriage, and I've seen CC embryos be the most beautiful, healthy children you've ever seen. And so that is the morphology of the embryos is one way we can look at it. And again, it's associated, right? But it's not a direct effect. But the other thing we can do is genetic testing. So if you decide to do genetic testing of the embryo, and we know that it is genetically normal with 98 to 99% accuracy, well, again, nothing's perfect, right? It's a screening test. We'd rather pick the genetically normal embryo first, right? And then also of those, maybe pick the best looking ones from there. But again, we've all seen everything. So we like to advise you, but it is important to know that even a fair quality embryo could potentially be a healthy baby. So it's worth trying. Another question I got was, what is the ideal number of eggs to retrieve for a high successful IVF rate? This will look different for every patient. So, I have retrieved from, unfortunately, 0, that's usually very few and far between, to over 50 eggs. Often patients who have a lot of eggs, like that number, those high numbers, a lot of them may be immature. So if you look at studies, somewhere around 10 to 15 seem to be an ideal nice number, but just know that that's not an absolute for everyone. There are patients who have more than that and they do really well. There are patients who have less than that and do really well, but that seems to be a good number. Remember, that number is going to depend on your age and your particular egg reserve and your antral follicle count. So if someone has an AMH of maybe 0.5 and an antral follicle count of 9, right? We're not getting 20 eggs out of that cycle, right? So we have to talk about like what we think we might get out of that cycle and what are our goals for that cycle with the protocol we're choosing. And remember that each month is a different event. So we may get a different response every month, and we have a different group of eggs, and we can tweak protocols. But remember that your baseline egg reserve is going to kind of dictate what our yield might be. But in general, when people get somewhere between 8 to 15 eggs, we do see good success. How do you choose an egg donor? I also got that question. So you can choose, you can have frozen donor eggs, and there's many frozen egg banks that we work with that you can look at. And then also you can use a fresh donor as well. So the donors themselves, like these, and what's nice about the egg banks or choosing a fresh donor through an agency is that they are screened beforehand. So these women are typically between the ages of 21 to 30. They are very healthy. They do have a high and good egg reserve. We make sure that they don't have any significant past medical history, and that they haven't had their own infertility or recurrent miscarriages, their family history, psychological history, and look at their genetic history. And so actually many patients are really screened out of this. So the donors that you see in either egg banks or in agencies or in practices, these are people who have already gone through a lot of screening. I think things to think about are like, what qualities are you looking for? Do you want the same ethnicity as you are? Hair color, eye color, you would know height, weight, and of course, but these things can be different between patients, and different people have different goals for what they want. The donors also you'll see their education level. They'll answer some questions. We do think it's important to just pick people who don't have strong family histories of a lot of cancers or heart disease, things like that. So in the frozen donor cycles, you'll see profiles that you can take a look through. And then also, with, fresh donors, you can look at agencies and see. Now, one of the difficulties with a fresh donor is that her life has to correlate with yours too, right? So she actually has to go through the IVF cycle. You have to make sure that she's okay, and then all her infectious disease testing is done. The nice thing about the frozen donor is that's already done. So they're there, and at that time, you may not wait a couple months for that donor to go through, because they're already there, and you can purchase them and have them shipped to the clinic. But I think it's a personal choice in looking at, those characteristics. And then of course, you just want to make sure that, they don't have any significant medical history or genetic history, but again, they would have been, eliminated they wouldn't have been chosen to be a donor by these egg banks. Another thing that's important, like let's say you have a male partner and he's using his sperm, you would make sure that donor, and let's say your husband does not carry any of the same recessive traits. So there is genetic carrier screening that we can do to look and see, do we carry a recessive gene that can be passed on to the child? And remember, if both partners have the same recessive gene, then 1 in 4 children may get that condition. So it's really important if you're using donor sperm, the donor sperms are also tested too. So you want to make sure that donor sperm and the egg donor, or your partner's sperm and the egg donor, do not have the same condition. That having been said, it is important, if you're going through fertility, that's something that we do offer patients. And it is recommended to think about, preconception genetic carrier screening, because we can do IVF to test the embryo and make sure that the child is not affected by that condition. Great. I think these were excellent questions. I'm going to wrap up tonight. I really appreciate you being with me. I could talk to you all night, and I do wish I could see you, but I hope you all have a wonderful evening and a great weekend, and I hope to see you soon. Okay. If you want to consult, please feel free to call our office or use our online form. We're all here to help you. Okay. I'll